Welcome to AETCM, the emergency medicine channel. 49-year-old female came to the ER with complaints of pain abdomen, distension of abdomen, and obstipation since morning. On initial assessment, airway was patent, breathing, saturation was 98% in room air with the respiratory rate of 20 per minute. Circulation, BP was 130/90 with pulse rate of 123 per minute and pain score of 8/10. At this point, we started her on injection PCM 1 gram IV. Coming to disability, patient's DCS was full, both pupils bilaterally equally reactive, and coming to exposure, patient was afebrile. We took adjuncts to primary survey, one VBG and one point of care CBC CRP. VBG is showing no acid-base imbalance, pH of 7.4 with a PCO2 of 34 and a bicarb of 22.6, lactate 2.2, potassium 4.4, sodium 126. CBC CRP point of care, total counts was 9.8 thousand, hemoglobin 8.8. Platelet 500 and a CRP of platelet 5 lakhs and a CRP of 118. Coming to sample history, 49-year-old female came to the ER with complaints of diffuse pain abdomen, high intensity, with complaints of distension and obstipation since today morning. Allergic history, she is not allergic to any known medications.
But here you need to explain that history, right? We are saying about pain abdomen. So site radiation.
So our patient is complaining of diffuse pain abdomen. Like she was not localizing. She's saying that diffusely she is having pain, which is very high intensity. Like she was having severe pain. It was associated with inability to pass stool as well as flutters, but there was no fever or history of any vomiting. On allergic history.
Now this patient, as you told, patient is having diffuse abdominal pain, but patient is telling intermittent episodes of pain, severe pain, right? And you're telling that patient is having obstipation. Now, since obstipation is not able to pass stools as well as flatters, you are suspecting a intestinal obstruction, suspected. But the pain diffusely available there is the one positive thing you are saying. Question is the pain diffusely present always, or is it intermittently present? Now, the very important question there is whether the patient is having a colicky type of pain, because your pain score is quite high, it's 8 out of 10. So, we need to ask, is it a colicky type of pain that comes and goes? So, if it is, patient is saying, yes, suddenly I get a severe pain which is very high intensity, then it slowly comes down, and when it comes, I feel like I want to pass stools, or I feel a movement inside the abdomen. It more looks like a intestinal obstruction. The pain itself will tell the history of intestinal obstruction, and most probably that type of pain is characteristically seen in mechanical obstruction. So that part of pain is very, but similarly this patient is telling, yeah, I used to have this type of pain till yesterday, but from today morning I am having severe abdominal pain which is always present. It's not at all relieving, which is more localized on my right iliac or left iliac, for some, means localized on a particular area more than the others, and it's more when I am moving around. So the characteristic of the pain has changed. So the initial pain, we know the pain itself is like a intestinal motility causing pain, colicky pain. But now that colicky pain has become a diffuse persistent pain which is movement aggravated. Most likely would have been
Perforation
peritonitis. So this is why that pain history, when we say these factors should be asked, patient may not tell these things very forthcomingly. You need to ask that. Okay.
Patient was having colicky type of pain only. Like when it comes, it's very severe. Would relax for some time. Not allergic to any medication, and
fever, no fever, no vomiting, right? No fever, no vomiting. Okay.
Then coming to past history, basically patient is a known case of CA adenocarcinoma colon on chemotherapy with capecitabine, oxaliplatin and bevacizumab. The last meal taken was today morning itself.
Similarly, in past history, there are a couple of things we need to ask about. Now, from the history itself, it's much more clearer that we are dealing with an acute abdomen. This is acute abdomen. One of the common diagnosis of acute abdomen is intestinal obstruction. What type of patients will you suspect intestinal obstruction?
Patients
Higher age group, right? More than 60 years is the most common presentation of intestinal obstruction. So, elderly age group fits the criteria. Then the question is, what is causing intestinal obstruction? So, in past history, there are a couple of things that will help you. What are the past history you should ask?
Basically, if she's a known case of any carcinoma like bowel,
Yeah.
that would be have like 80% chance that patients can go into intestinal obstruction.
Okay, so basically you have two types of intestinal obstruction. No, you have dynamic and mechanical. So in mechanical, you are basically dealing with a bowel loop which is not able to pass on to its content either due to a intrinsic intraluminal obstruction or it's a extraluminal obstruction. So extraluminal is due to anything inside the abdominal cavity and intraluminal is due to mass or other obstructions that is obstructing the normal flow of matter. So in history, important history is previous intra-abdominal surgeries.
Yes.
So any patient who has done a previous intra-abdominal surgery, we should suspect adhesions. And if possibility of adhesions, that is one of the most common cause of extrinsic intestinal obstruction. That one history. Then Crohn's history. Patients having inflammatory bowel disease, especially Crohn's, can present with intestinal obstruction. Previous history of intestinal obstruction is very important because any previous history of intestinal obstruction, more possibility is there for a recurrence of intestinal obstruction. So that history we need to ask. Okay, what else? What are the other histories we need to think about?
Some patients can be on antibiotic use. If you are suspecting toxic megacolon,
okay,
patient can history of antibiotic use following after which patient developed
toxic megacolon. That is true. What is the most common antibiotic?
Antibiotic would be
clindamycin. Okay. What else? What other much more commonly associated
hernias? If any history of
hernia history. Drug history, yes. Yeah. What is the most commonly associated drug history? Correct.
Painkillers.
Elderly patients can have cardiac disorder, most probably will be on furosemide. Hypokalemia. Similarly, elderly patients on furosemide developing vomiting develops hypokalemia developing this thing. So hypokalemia as the source of intestinal obstruction should be eliminated initially itself before we going for X-ray and CTs and all these things. So hypokalemia should be kept in mind and drugs causing hypokalemia. What else? Anticholinergics, correct.
Antihypertensive drugs.
Like calcium channel blocker, right? But that is basically we are saying that calcium channel blockers will inhibit the peristaltic. Not very common, right? We have like one of the most common antihypertensive drug is calcium channel blocker. How many patients develop intestinal obstruction? What are the other?
Painkillers.
Opiates. We should consider opiates in the current scenario because many elderly patients are carcinoma patients. So they may be getting opiates for pain relief. Morphine being the most common tablet. Tramadol also is very commonly used. So these things can cause intestinal obstruction. So opiates should be kept in mind. What else?
The radiation drugs, chemotherapeutic drugs.
Chemotherapeutic drug, direct radiation to the abdomen is a contributing factor. What else? Any other drugs?
Antihistaminics, antispasmodics.
Antihistamines, antispasmodics, much more.
Iron tablets.
Yes, iron tablets. Chronic iron use can cause intestinal obstruction. That's much more common in female patients. They will be having iron deficiency, anemia. So, iron tablet history is very important. What else? Any radiological investigations will do? What contrast? Barium.
Barium.
Yeah, barium meal can cause constipation. But barium meal nowadays usually is not commonly done because we have much more better modalities, very rarely done. But it's more commonly done in pediatrics. So pediatric patients presented with constipation, we have to ask about recent radiological barium meal history. What else? Any other drugs? Antidepressants and antipsychotics. Antidepressants and antipsychotics can cause significant constipation. So drug history is very important because drug history, most of the patients who have intestinal obstruction due to drug history doesn't require further management, rather than its dose adjustments and withhold of drugs itself will cure the patient, and supportive treatment only required. So reversible causes should be initially itself talked about. So in past history, uh, drugs, radiation, chemotherapy, previous surgeries, previous carcinoma like this patient, what else? Previous intestinal obstruction history itself. Uh, the more the intestinal obstruction episodes a patient have, higher the risk for another obstruction with a very limited time of interval of symptom-free interval time will be there. So this history should be clearly asked because these will give us a very clear history about how we are going to deal with it. That
So after that, we went ahead with the CT for the patient because already known case of CA bowel and now presenting with obstipation. So we took a CT abdomen. In CT abdomen showing circumferential wall thickening involving the sigmoid colon with significant proximal bowel dilatation, colonic loops.
okay.
And also, ascending colon also shows mild circumferential wall thickening.
Okay.
So, we started the patient on
But
antibiotics.
that being there, that's okay. We have done CT, but let's come. So this patient presented you. You took a history, proper history of pain. Then itself you have a suspicion of acute abdomen with this thing, right? Intestinal obstruction. Your past history, you got a carcinoma. So your suspicion of intestinal obstruction is higher. What is the next step? Examination. Yeah. So what are the things you will look into?
So on systemic examination, GI examination.
Yeah.
On inspection, the abdomen was distended.
Yeah.
There were no any scar marks as such. Then on palpation, patient was having tenderness.
Okay.
On palpation, diffuse tenderness.
Okay.
Abdomen was tense.
Okay.
But there was no guarding rigidity.
Wow, that's important there. We always have to look for guarding or rigidity because any area guarding rigidity is there shows localized peritonitis. Patient may not have broad like rigidity and all because that shows generalized peritonitis, which is a very later finding. So any peculiar area tenderness if present and the patient is having guarding, we should suspect peritonitis. So that's good thing. Distension of abdomen is a common finding. So will all intestinal obstruction patients will have distension of abdomen? Which type of patients will have distension of abdomen as a presenting complaint?
Large bowel obstruction.
Distal the obstruction, abdominal distension will be much more higher. Proximal the obstruction, patient will have emesis. So if your patient is having a ileal or a duodenal obstruction, patient's main presenting complaint is going to be decreased appetite, inability to eat, and multiple episodes of persistent vomitus, bilious vomitus. And distal the obstruction, there is a huge bowel segments there which will act as a reservoir. It can take up all this gas and fluids and keep dilating. So that patient main complaint will most probably be abdominal distension and pain rather than emesis. Okay. Now, as we told vomiting, we told obstipation, right? So all intestinal obstruction patients will have obstipation? No.
Patient can be the obstruction can be acute, subacute, or chronic. So in subacute or chronic, it develops over a period of time. So patient might have passage of stool, but it can be decreased over time. But there is no in acute obstruction, there can be sudden like obstipation features can be there, but in subacute, patient may still be passing flatus.
Yeah, so basically, as Dr. Shreya told, we can classify intestinal obstruction according to timeline, that is acute, subacute, and chronic, but also as complete and partial. So, complete obstruction is when there is a sudden cutoff point in the bowel so that a proximal and distal segment is made, and proximal segment will continue to dilate, acting as a reservoir for everything, and distal segment will collapse, but that collapse happens only after patient defecates, because the distal segment still has some amount of fecal matter, and patient can still go to toilet and can pass stools, and patient will give a history. When you ask, are you passing stools, patient may tell you, yes, I am passing stools. So passage of stools may not really rule out intestinal obstruction, because if at all it is a proximal intestinal obstruction, patient will have a large amount of intestine which has fecal contents, so patient can continue to pass stools. Some patients, especially intraluminal mass patients, for example, carcinoma, colonic carcinoma, let's say ascending colon, one of the presenting complaint is intermittent episodes of constipation and watery diarrhea. Patient will develop constipation due to the mass, because the fecal matter cannot pass through, and fecal matter will get stagnant there, and over time the bacteria will degrade the fecal matter, turning it into a watery kind of like material which can easily pass through the obstruction, and patient will present with the watery diarrhea. So subacute intestinal obstruction patients may have watery diarrhea like picture, which is not persistent. Patient may say, I was constipated for 1 or 2 days, after that I developed watery diarrhea, 1 or 2 episodes, then again I am constipated. So this history we can get that diarrhea. So do not think, basically it is, do not think if patient is passing stools, it's not intestinal obstruction. Patient can still have intestinal obstruction even though patient is passing stools. That is especially true in partial intestinal obstruction. So partial intestinal obstruction is when in adhesions or in hernial sacs, some part of intestine is stuck there, but not the entire intestinal lumen. So patient will have some amount of constipation because of decreased bowel activity and all, but patient will still pass stools. But patient will have abdominal pain which is localized in an area. So there is something known as closed loop intestinal obstruction, partial intestinal obstruction, and normal our bowel intestinal obstruction. So it depends on the presentation as such. Okay. So that is okay. What other in examination? What are the other features you will find in a acute intestinal obstruction patient? Clinical findings.
Sir, patient on auscultation, we can find increased bowel sounds. There can be increased bowel sounds, but if it has been present for a long period of time, the bowel sounds will decrease because the bowel will become hypoactive.
Okay.
Other than that, patients can have features of dehydration.
Yes. That's the most important thing. Even if we miss bowel sounds and all, patient's dehydration status should very closely be monitored. Patient can be severely dehydrated. Patient can have electrolyte imbalances, either due to emesis or due to loss of third space. Because bowel is getting obstructed, it can cause
peritoneum.
Transduction of fluid and electrolytes into peritoneal cavity, causing localized peritoneal collections. So because of that, patient will lose hydration. So that should be looked into. Dehydration level should be looked into. Okay, what else?
Hypotension, tachycardia can be present.
Yeah.
Other than the electrolyte abnormalities can be present.
Okay. So postural hypotension, giddiness, nausea, all these things will be there. Okay. So examination wise, these are the things that we look. Okay. Now coming to investigations. What are the investigations you want to send? What is the diagnostic investigation?
So CT.
CT.
Diagnosis.
Gold standard is CT, no doubt. But what is the most common diagnostic method that you use?
X-ray. We look
X-ray.
X-ray detector.
Because X-ray is the most commonest, easiest and inexpensive test you can do to identify a intestinal obstruction. Much more readily available also, right? Okay, so how do you take X-ray? What are the films that you want?
So we take an X-ray erect abdomen, and so if we are suspecting perforation at all, we take a chest X-ray to look for any air in the diaphragm features.
So chest film with both diaphragm to look for air under diaphragm for perforation, and X-ray abdomen, erect and supine, right? And if at all this patient is very debilitated patient or a amputee patient, what will you do?
Lateral decubitus, X-ray lateral decubitus with both diaphragms.
Yeah, so since if patient cannot stand, we can take a X-ray supine, abdomen supine and lateral decubitus. You can take and look for airflow levels. So what are the cutoff level for airflow level? How many airflow levels are normal?
Up to 3 are normal, sir.
Yeah.
If it's more than 3, then we're considering obstruction.
Yeah, so up to 3, which is normal physiological airflow levels in the body, is termed as normal. Anything more than that, we have to suspect intestinal obstruction. Good. So airflow levels is the easiest thing. What is the next investigation of choice? You took X-ray. X-ray is showing dilated bowel loops, gaseous dilated bowel loops, but you really can't identify any airflow level. But clinically, you suspect intestinal obstruction. What is the next step?
USG we can do.
USG you can do.
Bowel.
What are you looking for in USG?
Dilated bowel loops if present.
Dilated bowel loops. But dilated bowel loops you already know in X-ray, no? So what is the extra thing you can ask ultrasound means radiologist to look for? Bowel edema. So bowel edema means there is inflammation in the bowel. On this context, it can be intestinal obstruction. So bowel edema, that's a good answer. Bowel edema you can look for. Okay, but ultrasound is very difficult because as we are telling, these patients are having obstruction where air will be there. We are swallowing air in every minute, right? This air is going to be stuck in bowel, and the air is a very bad conductor of ultrasound, and radiologists may not be able to help you. So, what is the next investigation? Best investigation? CT. So, how do you take CT? CT abdomen plain, contrast?
Contrast is better, sir. If possible, to go for contrast to exact location at the edema, like.
Yeah, basically, we want contrast to identify what type of intestinal obstruction are we dealing with. For example, like if it is an intravascular, intraluminal intestinal obstruction, what is the type of mass? Is it a growth? Is it something else? To know about the further causes of intestinal obstruction, it's better to do a contrast. But is that necessary?
No.
No.
CT
abdomen plain is adequate to diagnose intestinal obstruction. What is the problem if you do a CT abdomen with oral contrast?
Oral contrast, peritonitis can happen, no?
Not only peritonitis, already patient is having obstruction. So if a patient who has abdominal distension and features of obstruction is there with a significant backflow, back pressure, you should not give anything orally. There is a high risk that patient will vomit and aspirate. In such patients, even before taking CT, you should put a rice tube and decompress the abdomen so that patient's intestinal pressures will reduce and there will be reduced chances for emesis. IV contrast can be given if you are suspecting extrinsic causes for obstruction or intrinsic causes where you are suspecting carcinomas. So in a single CT, you can get diagnostic as well as further prognostic details. But from an emergency standpoint, CT abdomen plain is well and good to diagnose intestinal obstruction. Okay. CT will usually show a transition point and a proximal segment which is dilated out. Okay. Now, diagnosis part is done. Let's come to management. Okay, what are the things that you need to manage in this patient from an emergency perspective?
So initially we'll put the patient NPO.
Okay.
NPO. Then if abdomen is hugely distended, we'll decompress the abdomen by putting a Riles tube.
Correct.
At the same time, we'll start hydrating the patient because this patient might go into dehydration.
Good. What is the fluid of choice?
MS. RL.
Plus,
Vomiting.
yeah, near to isoosmolar, physiologically true fluids. So, better will be renal lactate or plasma light, something like that. NS is not a bad answer, but better is electrolyte supplementation, right? Okay, then.
And antibiotics if the patient is having features of sepsis.
Prophylactic, patient need not have features of sepsis. Patients once developing intestinal obstruction has a high probability of
Developing
peritonitis, perforations. Because of that, you should always put a patient on prophylactic gram-negative coverage antibiotic. Ideally, because you are expecting perforation. So basically, E. coli or other gram-negative organism is what you are expecting to be the cause of infection. So gram-negative coverage should be properly given for the patient. Good, antibiotics. Then what else? Pain. Patient presented to you with pain. So pain management, what will you give?
So we started PCM. NSAIDs can be given.
Uh.
Prefer to avoid opioids
Yes.
because of the...
So opioid should be a last line management because that will worsen the symptoms. But if you have a patient whom you are sure that will be taken for operation or intervention, then opiate should be given for that patient because it doesn't really matter whether opiate will cause intestinal obstruction because patient is taken for surgery. But if a patient is having subacute intestinal obstruction or partial intestinal obstruction and doctor is asking for a conservative line of management, it should be antispasmodics with NSAIDs. Okay? Okay, so pain relief. What else? Anything else? That's it. What are the complications you should expect in a suspected intestinal obstruction patient? Perforation, of course. So basically, bowel ischemia and bowel gangrene is the complications you should expect, and perforation is a side effect of that same thing. So intestinal obstruction can develop gangrene due to the pressure effect, or can be due to the decrease of blood flow into the lumen. Both conditions will cause intestinal gangrene, then necrosis, then gangrene, and which causes perforation. How can you predict intestinal gangrene or necrosis?
Lactate.
Yes. So lactic acidosis is one of the tests that can help you suspect a ongoing bowel ischemia. Like how we use lactic acidosis for SMA, SME thrombosis, here also lactate will be elevating, but not in a very rapid manner or not in a very high manner, because in SMA, SME thrombosis, we are expecting a huge amount of bowel to be ischemic. Here it's only a small part. So we may not get a very large value of lactate, but serial lactate elevation in spite of a good perfusion should make you think about bowel ischemia. Okay. Okay. What are the features of perforation? If at all a patient perforates, earliest findings will be sudden worsening of pain, sudden worsening of vitals, severe tachycardia, acute hypotension. These are the findings. Okay. Anything else to be thought about? Etc.